Welcome to our live webinar titled Complementary Therapies for Patients. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Mikhail Kogan, who is the Medical Director of the George Washington Cancer Center for Integrative Medicine. In addition to multiple research and teaching responsibilities, Dr. Kogan serves as an Associate Director of the Geriatrics Fellowship Program and provides geriatric consults at the George Washington University Hospital. Dr. Kogan also serves as the Associate Director of the George Washington Interdisciplinary Integrative Medicine Fellowship. With that said, it is my pleasure to welcome Dr. Kogan. Thank you for joining us.
Well, thank you so much. Thank you, Lee. Thank you, all the organizers. I've done this talk before several times. It's always a pleasure to speak at AMD SIF events, and also thank you, sponsors. Well, so with no further ado, let's proceed. So I don't have any specific financial disclosures, although I do practice what I will cover today in my own clinic, which is actually affiliated with the university, but it is my own practice. So today we're going to cover some basics as to what and how integrative medicine and alternative medicine fits into care of cancer, and specifically as it applies to myelodysplasia. And also we'll talk about what specific biologic treatments are applied, what is the evidence. We'll cover a little bit about diet, although this talk is not specifically about nutrition. And then we're also going to concentrate on systemic issues that often contribute to cancer progression and maybe even occurrence of cancer, and could improve chances of responses. And then, of course, we're going to cover how to manage some symptoms, and also how to navigate the pretty complex and often very obscured and often, frankly, poorly evidenced field of complementary and alternative medicine. So let's move to the next slide. So CAM, or full term complementary and alternative medicine, is defined as something that is in relationship to a Western model or allopathic medicine. So complementary means with, and then alternative means instead. Generally speaking, this is a somewhat an outdated terminology. We have been, in the past decade and a half or 2 decades, been trying to walk away from these terms, going towards what's often called an integrative, because that's really how we practice. So we don't really practice either with or instead. We really practice as a model of integration, where oncologists could easily work with, say, acupuncturists to try to control a specific symptom. And often the practice itself can get quite complicated, because in reality, some of the modalities may or may not be covered. Some of the oncologists may or may not be aware of certain things. So quite often, the core of the practice that we do occurs between oncology centers and an integrative centers, and then there is an integration between those two. So let's move to the next slide. So the integrative medicine is really the term that over the past 2 decades kind of took over and replaced the word CAM. And it's a bit more than just saying, look, we're going to add some modality to a care of a given patient. It's really the philosophy that's somewhat, I would say, different from the standard model. And in the integrative medicine philosophy, there's one concept that I specifically want to highlight. And it basically says that if you remove the obstacles to healing in someone's care, that their innate capacity to get better will manifest. And that is not something that typically is taught in medical schools. And that's also not how oncologists usually practice. And you could argue that this is not necessarily true, or there's not enough evidence for that. But this component of, we can get better on our own. We do have innate capacity to come back to a balance, and often even literally cure some diseases internally without interventions. That has more to do with a philosophical understanding of how diseases come. In standard approach, the idea is that there's a diagnosis and then you have to attach the treatment to it. In integrative medicine, we try to think about, well, what is the driver of a condition? So what caused the problem? So if you come and you say, look, I have a given cancer, I'm not only going to say, look, well, there's a chemo, but I'm also going to say, well, is there a driver? Or is there a systemic issue that have contributed to manifestation? And as you'll see through the presentation, we'll talk specifically about some drivers are known, of course, some are not. And then those that are known, we can do something often about it. So let's move on. So very high percentage of cancer patients, of all cancer, actually uses CAM, but specifically as it applies to lymphomas, it's over 50%. And if the patients are hospitalized, it's even higher. So let's move on. So this is important since I am an academician, and I'm not going to cover probably some of the topics that may be quite interesting for some listeners, but they may have no evidence, or they may simply be lacking a degree of understanding from basic principles, and thus I would expect that the level will be irrelevant completely. There are actually more bullet points on this slide. So level 1 is the top level, is what's often considered a standard of care, where there is a definitive trial that's proving or disproving efficacy of given approach. Level 2 is there are studies, but they're just not as high quality as we expect. So they could be non-randomized, or they could be retrospective. Level 3 is something where, for example, there is not enough evidence, but an expert who has been in the practice of a given modality for quite a long time can say, look, I have a number of cases that I've treated, and this is what I'm seeing. And then level 4 is really, there is no clinical data. It's all in an animal models or in petri dishes, or what we often call an in vitro data. So biologics that we're going to cover are listed here. Some of them you're, of course, familiar, some probably not. And we're going to go just through each one and discuss them in a little bit more detail. So let's go to green tea first. So green tea is really all kinds of levels except for level 1. There's no specific MDS or AA positive studies, but there are quite a significant number of trials and positive data for chronic lymphocytic leukemia. And quite often, I personally translate that data to the MDS and NAA. And I'm going to just say a couple of words about not only the level of evidence, but the importance of understanding that when you're talking about chemotherapy, you really want to have level 1. Why? Well, because you're taking something potentially toxic. If you're talking about green tea that's been consumed for millennia with very little, if any, side effects, unless you're taking huge doses, you may say to yourself, look, do I really need a level 1 data, or am I okay with level 2 if all it means that I'm going to take some cups of green tea and potentially improve my response to whatever the treatment, whatever else I'm doing. So that's an important aspect. The safety component of a given intervention is also important. It shouldn't be ignored, meaning that the safer the modality or the approach, not that you don't want to have better evidence, but often we just don't have that evidence. And so you could arguably say, look, I'm okay with level 2 with non-randomized prospective studies if they're showing a possible benefit because it's a safe, often very low cost and easy to take approach. So green tea is high in bioflavonoids. The main one often thought to be EGCG. Don't ask me to spell that. I'm not a good speller. It's a very long name, but you can look it up. And most of the products, by the way, on the market as in extracts or capsules, etc., powders, would contain percent EGCG on the label, and you want to make sure that you look for that, and you want a higher percent if you can find it. Of course, green tea contains lots of other nutrients. There's caffeine. There's also something called L-theanine, and that's an interesting molecule. It actually is a quite calming and inhibitory modified form of amino acid. It doesn't actually come from lots of other foods, and it tends to, the reason people don't often get a lot of jitterness from green tea specifically when they drink it, although of course some can, but it's the L-theanine, it balances the caffeine. But usually when we use green tea therapeutically, either in a powdered form or in capsules, products or extracts will probably have caffeine extracted. So it'll be a trace caffeine or just a very small amount. And so the reason this whole field or the green tea came to attention quite a long time ago, actually decades ago, is that there's been a lot of observational cohorts showing that in the countries where there's a very high consumption of green tea, all cancers, not just myeloid tumors, are at much lower rate. And it's not quite clear, given that there's very little randomized data as a treatment, but it does appear that as a preventive modality, green tea is one of a few easily obtainable, safe, and quite inexpensive approach. So let's go to the next slide. So a practicality, actually before I talk about this, this is a study about 10 years ago that demonstrates that ingredients in green tea in the large cohorts decrease chances of hematologic malignancies, and that's what I was just mentioning before. Now, again, this is not a treatment study. This is basically saying, look, if you are consuming a lot of green tea, your chances of something are less. So, whether you can apply that and say, if you're diagnosed with a condition and you start drinking green tea, you're going to have a better outcome. That's a stretch that we make, but given the safety, I personally believe that that's a reasonable stretch to make. So let's go to next slide. So, and this was the conclusion, so risk of hematologic, okay. So I generally recommend people to go with a matcha green tea, and the reason is that it's a lot more concentrated. So when you drink a regular tea, you boil the water, or you just make it very hot, close to boiling, and then you sip the leaves in there. Then you drink the tea, but the leaves stay behind. The matcha is quite unique because you're actually drinking the tea, the leaves themselves. It's a powdered, usually thought as Japanese green tea that actually can be extremely expensive if it's ceremonial grade, but usually I recommend that people simply take culinary form that's used not just as a tea, but as a taste for foods. In fact, for a long time, I have my kids, when they buy ice cream there, or actually my 11-year-old now makes his own ice cream. So he would take the green matcha powder, add it to the ice cream, and then we have green matcha ice cream. So important point about matcha is you must get it organic. Unfortunately, green tea is one of the very highly polluted foods, especially when it's grown in certain parts of the world. But just to be safe, I recommend specifically green tea, always get it organic so you don't get any pesticides. And the dose is varies quite a lot, whether if you're using it as a tea, I recommend 1 teaspoon twice a day, but you're gonna have to gradually increase the dose, because if you go straight up to that dose, you may actually feel, a lot of people feel nausea while you're adjusting to the taste and to the volume of flavonoids. It's actually flavonoids called tannins that can cause upset stomach. The key to solve that is to always take it after food. If you take green tea on an empty stomach, you may actually have more nausea, not less. And if you don't like the taste, or it's just you prefer capsules, again, as I said, there are lots of different products on the market. And usually you want to try to get 50% or at least 40% EGCG with taking several capsules a day. For the CLL, although it's not relevant, the dose is actually higher in the studies. So it's not uncommon that I have some of my patients take as much as 6 to 9 capsules a day. So let's move to the next slide. Boswellia is another pretty well-researched supplement. Now, in contrast to green tea, Boswellia is not usually consumed as a food, although you can see it's a raisin that's used for it's used to be for the smell of it. It's used in medicinal armamentarium in a number of Asian countries for thousands of years. So it's a really old approach. It's very potent anti-inflammatory, so it actually commonly used in rheumatologic conditions, and there's a data that is really good for those conditions. I think, unfortunately, for lymphomas, leukemias, and myelodysplastic syndromes, the grade of evidence is pretty low. I don't think there's even prospective studies, but as an anti-inflammatory and something quite reasonably safe, this is also one supplement that I often recommend to my patients. Let's move to the next slide. So of course, the mushrooms, we're not talking about generally edible mushrooms. We're talking about specifically medicinal mushrooms, such as shiitake, maitake, chaga, turkey tail, and several others. So in contrast to what we've covered so far, there actually are level 1 studies. So there's a randomized controlled trial showing benefit of several mushrooms, and we'll look at some of them. Now, this is one component that's kind of hard to cover in a lecture because it's a whole medical field in itself. There are literally probably close to a dozen of mushrooms with documented possible benefits, and how to use them, in what combination, how to make it reasonably cost effective. That's a whole lecture in itself. Mushrooms can be extremely pricey, especially when they are extracted in a certain way without alcohol in what's called a hot water, and concentrated very heavily so that you take less capsules or less powder. To taking a big bulk here, it's not very easy. Traditionally, they have been used as infusions or teas. We have not done that for quite a while because that's really difficult to do for most people, meaning you have to buy a dried material as a whole mushroom, dried mushrooms, and then boil it and understand the ratios and how to mix them. Nobody practices this way nowadays. We simply use either a standalone, an isolated specific mushroom, say shiitake, or a concentrates in the mix. Now, of course, some of these foods you can buy. So maitake, shiitake. The problem is the amount of active ingredients that is needed is really hard to get from just eating those mushrooms. You probably need to eat something like several pounds of shiitake every day to get a true medical benefit. So let's go to the next slide. Of course, the turmeric or curcumin is a big one. And this one, even though for specific AMDS, we don't have the grade 1 or level 1 evidence, but we do have level 2 and 3. This one is probably, in terms of, if I were to rank things down, I'd probably rank it really high. Now, by the way, the flow of order here is not necessarily in any specific, there is no, I would actually say that maybe green tea is just as important as turmeric, if not more important. And in fact, the level of importance is very difficult to assign because it also depends on a specific individual, and often if you have other comorbidities, let's say arthritis and some cancerous process, then you really want to address both instead of just one. So the turmeric or curcumin is very potent anti-inflammatory. It actually works in a way similar to Motrin or Advil, or what we often call non-steroidals, by downregulating COX-2. In vitro, it actually is shown to be very potent cytotoxic and chemosensitizing agent, meaning that when somebody takes turmeric, when you add chemotherapy to it, it actually tends to kill certain cells faster. Now, that's not necessarily translatable clearly to the clinical practice unless you can demonstrate the actual better outcomes in patients, but it's very important to notice. And the typical dose is about 1 to 2 grams of extract per day, and that equates somewhere between 1 teaspoon to 1 tablespoon. And the difference in range is based on an actual percent of active ingredients. So if you buy a turmeric, organic turmeric, again, notice that I will go back to certain things and specify which ones must be organic. Mushrooms is maybe also just as important to be organic. The reason for that, unfortunately, there are a lot of really low cost products on the market that we know come from outside of the US, and they're often contaminated, and the studies have been done to show it. So I tend to always recommend get an organic and try to get an US source if you can. So the reason there is a grade or a large separation between how much to take, it's based on a couple of things. So one, this one is actually can be titrated slowly and you can observe the effect, but it also is based on interactions. So high dose of turmeric can cause some interactions with medication. So it's actually quite important. If you take more than a teaspoon per day or more than 2 grams of extract for any reason, you probably should talk to a provider who can assess whether for you it's safe. So let's go to the next slide. So I guess I'll try to do questions after. I know there's some questions coming up. So turmeric, as I mentioned, it's sensitizing cancer cells to be killed faster, and these are the specific agents that have been studied and shown that they actually synergistically can work better when curcumin is added. Let's go to the next slide. So melatonin. Melatonin is one of my favorite ones. It's also a pretty important supplement during COVID times, believe it or not. It's a misunderstanding that melatonin somehow is a universal effect, has positive effects on sleep. That's actually a very minor effect. It just so happened that it also regulates the sleep, but it's a very potent antioxidant and anti-inflammatory, even at the very low doses, like 1 milligram, for example. And it's actually thought to be traditionally, the reason for that effect is that at night, when we sleep, we are not only controlling our inflammation better and helping our natural detoxification system to work better, but we also tend to regulate the inflammatory response at night during the day. So whatever happens at night regulates inflammatory effects during the day. So melatonin there has a crucial role. This one actually has level 1. So we do know that there's a really large number of randomized clinical trials. There's meta-analysis, meaning you take lots of trials, put them together to try to boost number of participants to increase the statistical power of data. And so the usual dose, you get up to 20 milligrams, but you want to start at the low dose. If you start straight at 20 milligrams, you're probably going to get very lethargic and sleepy next day. So you want to start anywhere between 1 to 3 milligrams, but definitely no more than 5 and titrate up. Let's go next slide. This is a general diagram how it works. As I mentioned, it's a very potent anti-inflammatory and antioxidant, but actually has a profoundly wide range of effects, and they're quite well understood, and this is just lists what we know. So let's move to the next slide. So vitamin K2, it's probably not all of you, I'm sure everybody heard of melatonin, green tea, turmeric, but not probably everybody heard of K2. That's one of my all-time favorites. And the main reason is that we have a very specific level 1 data on MDS. I'll show you a study in a second. And here, what's really important to understand that vitamin K is a group of vitamins. They each have their own role. So for example, vitamin K plays a crucial role in clotting. Vitamin K2 has no role in clotting, so it's completely safe to take if you're on anticoagulants, just K2, not K1. But its role actually is much more in bone health, muscle health, and cardiac health. So it's a really important analog or similar hormone to vitamin D, although its function is different, but structurally and how it affects the body through which receptors, it's the same receptors. So let's go to the next slide. So this is the trial that's actually quite old by now, so it was published 20 years ago. But you can see that if you give the vitamin K2 to patients with refractory anemia with excess blasts, you actually have a really good response. Now, this is, of course, really small trial, but it is a controlled trial. So based on this data, there's been adaptation of K2 in several countries, including Japan, as a quite common treatment. Now, I think in Japan, they use more K3, not K2. K3 has some of the similarities to K2, but it's actually a synthetic form, so it has to be manufactured, versus K2 is extracted. So K2 is not made by our own bodies. It is made by our own gut microbiome, so by bacteria in the gut. So if you're somehow had chronic intestinal problems, taking multiple courses of antibiotics, for example, the K2 is quite often gets depleted. Now, the good news that K2 is now supplied in almost all high doses of vitamin D. In fact, I don't even remember when I last prescribed vitamin D without K2, just because the cost is the same. It's a lot easier to give with K2, and it's quite beneficial. And especially since we're finding out that a lot of patients with all kinds of chronic diseases, including all cancers, have disrupted microbiome, and the data on that is growing. So I often prophylactically give to all of my cancer patients K2, worrying that they may have microbiome shifts. Let's go to the next slide. So this is in a study, a prospective trial specifically in MDS, also demonstrating benefit. Now, the reason I'm bringing this study is a specific dosing. So you can see that 45 milligrams of something called menatetrinone, it's also known as an MK4. Now, this is important. If you go on whatever your favorite supplement site and you try to buy, you're going to find two common forms of K2. What's called MK4 and MK7. Unfortunately, there's zero data on MK7 for any cancers, and MK7 only has a pretty decent data for conditions like osteopenia, osteoporosis, or bone loss. So because of that, I never use MK7. It's a lot easier to find. It's cheaper. And there are only few companies that make MK4, and the doses really needs to be, I would say, 30 to 45 milligrams, versus MK7 is in micrograms. So you may find something like 100 micrograms of MK7, but know that that's not the right product. So let's go to the next slide. Okay, so quality here is very important. Again, I already covered that, but in reality, the prices for the MK4 are quite higher. So the way to, actually, the prices have been slowly coming down. So I think it's probably closer to $50 to $60 rather than $100, say 5 or 6 years ago. So, and as I said, always combine it, especially if your vitamin D dose is high. Let's say if you're taking 5,000 or more vitamin D, it's really important to take some K2 with it. It's more of a theoretic fear that when you take a very high doses of vitamin D, you actually potentially cause pseudo vitamin K2 deficiency, because the same receptor is affected. And when you give high dose of D and there is no K2 impact, you may actually have some negative effect of that. And that's actually, I'm not just saying this based on theoretical, there has been data that patients who take very high dose of vitamin D, they actually have problems, including increased risk of mortality. So patients with a super high levels of vitamin D, something like above 60 of vitamin D 25-OH, there is a concern that those patients may have problems. And I personally believe that that is really because of the K2 becomes pseudo-low. So the level may be normal or okay, but because you're taking extra D, you actually have to overcompensate by taking extra K2. So let's move to next slide. Of course, we've got to talk a little bit about vitamin D, since it's a very close analog of K2. It's a hormone. It's really a misunderstanding. It's not a vitamin. And there's not a lot of data, there's no direct data in myelodysplastic syndromes to say that if you take vitamin D somehow, there's a better outcome. But it does make sense to optimize the level. And actually, I would say since we're in the time of COVID, I also would say now we have a pretty good data to say that you want to optimize your vitamin D level in times of COVID. So in case you do get sick, you don't get as sick, because patients with vitamin D deficiency clearly have much worse outcomes. And in fact, there are places like Spain, for example, universally adopted vitamin D supplementation based on some of their studies. Let's go to the next slide. So this is just a list of all the specific assessments that were done looking at in AML, MDS, what happens if either you give vitamin D or if you assess vitamin D level. But unfortunately, these are all either short studies or they were not controlled enough. So it's kind of hard to make a summary of all of this. That's why I really put that's a level 2, since none of the studies are really quality, large randomized studies. So let's move to the next slide. So the practical way to think about this. So, keep the level somewhere between 40 to 60. 60 to 80 level is sometimes appropriate for some patients, but you have to really talk to a provider. It has more to do with how you take vitamin D and what the goal is. The doses, weekly doses that sometimes advocated, I strongly discourage, because again, those are the doses that we see most side effects with. So I usually go anywhere between 2 to 10,000 units. And once the level is achieved, we drop the level down and maintain the level. And as I said, my preferred level is 40 to 60. Unfortunately, sun exposure is often not enough. Plus, if you spend hours in the sun without sunscreen, you can also have skin cancer. So you have to be careful with that. And I personally find that the liquid forms of vitamin D for a lot of patients are better absorbed. I'm not exactly sure why that is, but that seems to be consistent over a decade of my practice. So let's move on. Okay, and then, so the reason you see this topic included, not necessarily because there's really strong evidence, but because I have personally lots of experience with all kinds of cancers and vitamin C, including CLL, including MDS and aplastic anemia. And this is one treatment that can actually be quite powerful. I have seen cases, I wouldn't say a cure, but a long-term remission. Unfortunately, while it's extremely well tolerated for anybody who does not have G6PD deficiency, which is easy to check and pretty uncommon, we don't really see much of side effects. In fact, the side effect is usually I feel a lot better. And if you take it right after chemotherapy on the same day, even quite often that dramatically decreases chances of toxicity of the chemotherapy. And that, what I just said, actually has level 1 studies randomized, although not large, but quality randomized studies showing quality of life is improved. It is not an antioxidant. This is really important to understand. When you're talking about intravenous form of vitamin C, it's a very potent chemotherapy. So it's a pro-oxidant, so it generates hydrogen peroxide, and normal cells have an enzyme called catalase that can easily break hydrogen peroxide, but the cancer cells universally lack the capacity to get rid of the hydrogen peroxide, and so they basically, you're basically utilizing this conversion, so the vitamin C in this setting is a pro-drug. That drug is hydrogen peroxide, but vitamin C makes the hydrogen peroxide to be generated by the production of the cells. And that's a normal way that the metabolism of high dose of vitamin C occurs. Let's go to the next slide. So as I said, the chemotherapy is tolerated a lot better. In my clinic, we've seen hundreds of cases of over the more than 2 decades of using this. We've seen hundreds of cases of long-term survivors. We've tried to publish some of this. The problem here, it's really difficult to publish cases that tend to, go against the grain of a typical understanding. And the problem is these cases tend to be very complex, and the publications of such cases is fraught with all kinds of criticism for a good reason. So, but there are specific trials that, and they're increasing in numbers. So, I think the first trial was published about 10 years ago, and it was first with pancreatic cancer, but now we have an ovarian and colon and breast. So the data is gradually increasing, but I think we're not going to get to a level of evidence needed to make this covered by insurances anytime soon. And unfortunately, this is not cheap, and it's mostly expensive, not because the vitamin C is expensive, that's actually quite cheap, but it's because the infusion itself. And so, you're looking at spending $100 to $200 per infusion. We've had situations where some insurances will cover the infusion part of the, which is most important anyway, most expensive anyway, but the nutrients themselves are never covered. So let's go to the next slide. So there are lots of other supplements that can be taken for different reasons. So for example, I don't consider fish oil as anti-cancer. I consider it as a basic support, especially during the chemotherapy, when the body often goes through a pretty high spike of free radical damage, and an anti-inflammatory effects of fish oil can be very beneficial. Ginger can be very good for nausea suppression, and then of course there's also support of the gut, which quite often ends up being quite distraught by chemotherapy, so glutamine is very good for that. I do want to say just a little bit more about mistletoe. So we've been now using IV and subcutaneous injections of mistletoe in our clinic more than 5 years. It's an interesting data. There's no data for MDS and AA, but we have seen a long-term survival with these treatments, and there are actually 2 current trials undergoing at NIH. One is for breast and one is prostate, and we do think that, well, COVID put the wrinkle on the timing of both of these trials, but they should be finished in the next couple of years. So we'll know more. But in Europe, this is very commonly used, and we have seen, especially in combination of mistletoe and vitamin C, pretty interesting results. So let's go to the next slide. And medical cannabis I decided to include here for 2 reasons. So one, I have a lot of my patients asking, well, should I take a cannabis to cure my cancer? Unfortunately, there's really no evidence whatsoever, and there's definitely no evidence for MDS or AA. However, if you look at what happens in vitro or in animal studies, we do have evidence. We also seemingly have possible evidence in humans for brain cancers. This is really early. The fact that number of cannabinoids have very potent anti-cancer properties not necessarily clearly translates to humans. However, if you're looking at the symptom management, that's where cannabis shines. In fact, for lots of symptoms, now cannabis is my first line, not even second, because it's so effective, so low side effect, such a good side effect profile. And it's the only treatment I can think of that at the same time can treat multiple problems. So let's say you have a chemotherapy regimen that's causing pain, nausea, anxiety, insomnia, or disease causes anxiety and insomnia and pain. But you have all these 4 things listed. So the cannabis is the only treatment I can think of that will treat everything. And it can be reasonably low cost when you treat symptoms. And we're talking, $50 to $100 a month. And it could be really easy to take, meaning there's so many dosing variants. You don't have to smoke it. In fact, I never recommend smoking or inhaling simply because the risk of that. But you can use it as a drops under the tongue. You can take it as suppositories. You can take it as topical. You can take it as edibles like chocolates or chews. So there's a variety of ways to take it. You can also titrate it easily. So you can start with a tiny doses, even less than 1 milligram of THC, and then gradually increase the dose. That almost universally decreases chances of psychoactive side effects, meaning getting high, while there's you get therapeutic benefits or therapeutic effects. Although frankly, While psychoactive effects are often listed as side effects in patients with severe symptoms with advanced cancer, frankly, I'm yet to hear any of my patients say that that's a side effect. It's often a very needed break from suffering. And there's a whole sort of domain of that, which again, could be a whole lecture in itself. So let's go to the next slide. And the evidence, by the way, is very solid. So this is a National Academies of Sciences. We are not talking here, you know, a government or some commercial entities controlling the data. This is a top-notch reporting agency in the country. Let's go to the next slide. And so you can see that for treatment of chronic pain and as an antiemetic for chemotherapy-induced nausea and vomiting, there's a conclusive or substantial evidence. That means it's a level 1. It means that there's a large randomized trial supporting the benefit, and there's no basically argument that that's effective. There isn't. You know, there's lots of other, you can look up the report online, it's free. So you can just simply Google 2017 NAS report on medical cannabis effects on health, and you will find everything that's on this slide. So let's go to the next slide. Lots of patients with cancer, of course, using cannabis. That's not surprising. Of course, in Canada, since it was approved for both recreational and medical for the whole country, there's just a lot easier access. So you would expect that more patients will use it, and also due to the lower cost as well. So this is a use among cancer patients is very high. And this is, by the way, is even higher now. Let's move to the next slide. So some words of caution in terms of vitamins and supplements. So first of all, stay away from individual antioxidants. They do nothing, and they're probably harmful. And that's not just for cancer, for any period, for anything. There's really no good role unless you take them in a very specific reasons. Let's say you're selenium or vitamin E deficient. Well, of course, that's different. And making sure that you're also taking those nutrients as a as part of a well-balanced diet. I generally tell people never buy my vitamins, or specifically multivitamins, in any retail stores because they're harmful, and there's a good evidence for that. You really want to work with someone who understands the retail versus nutraceutical grade. So the nutraceutical is the fact where each batch is tested and the quality of that of those brands is equal to the drugs, versus the retail batches are not tested. What's on the label was often not in the pills or in the capsules, and you really don't know what you're buying. And they could be a lot cheaper, but you know, you get what you paid for. You know, but you really want to have this whole area navigated by somebody who's really learned and understand and have access to quality products and know how to coordinate the care. And please avoid suggestion by the clerks in the stores. There's been, in 2010, I believe, Office of Government Accountability did this study where they sent agents, undercover agents, to different stores. And without naming any stores, I will tell you that it was horrible. In the many stores, clerks would say something like, oh, you can just stop this medication and this supplement will cure you, which is nonsense almost always. And so we do know that, unfortunately, because this whole field is unregulated, you really got to work with someone who understands the intricacies and staying away from sort of, my friend said this, or, you know, clerk said that. That could really lead you astray and in a really bad places. So let's move on to the next slide. So the diets, I'm not going to spend a lot of time. It's not really a dietary lecture, but you know, we do have plant-based diet evidence for all cancers. Now, it's not really clear whether you must be vegan, vegetarian, or whether you could just be a near vegetarian, what's often described as close to vegetarian diet with a very small amount of animal protein. There's not a lot of data on a high fiber intake. There are lots of different diets: ketogenic, Garson, Gonzalez, microbiotic. Unfortunately, none of these diets have been studied well enough for anybody to sort of say this is the way to go. The only thing I would put out here is that ketogenic does have some evidence for brain cancer, but really no evidence for other types of cancers. So we don't really recommend that. But we do often come close to ketogenic, so we often cut out most of the simple carbs and also keep the total amount of carbs as low as possible without going into a full ketosis. So the sensible approach is really low animal protein, lots of organic foods and lots of greens and fruits, and making sure you're avoiding the dirty dozen. So that's what it means by lots of organic foods. Dirty dozen, I recommend everybody to look up EWG, Environmental Working Group. So that's the list of 12 foods that very highly polluted. So you want to make sure those you get organic. Let's move to the next slide. So, and I'm going to cover a little bit some of the systemic issues because I think they're really, really important. And unfortunately, they often are kind of ignored by the standard of care. So first one, we'll talk, I'm not sure if there's a problem with this slide. Let's go to the next slide. Oh, I see. Okay. So gluten sensitivity is first. Oh, I think we skipped. Yep, there we go. So gluten sensitivity is important. Chronic detoxification problems is critical, and there's some evidence specifically for AA and MDS, so we'll cover that. So let's go to the next slide. So gluten sensitivity is pretty chronic. We do know that historically it's a relatively new condition. It's probably related to the fact that we've now started growing wheat for the past 10 or 20,000 years. And the percent gluten is steadily increasing. And so it's probably the fact that we're increasing, seeing increased celiac and gluten sensitivity is related to the fact how we coexist with the plant itself. Let's go to the next slide. So there's pretty clear epidemiologic links to all kinds of cancers. There's no evidence specifically for MDS or AA, but you can extrapolate that. Unfortunately, figuring out who's gluten sensitive, who's not, is not straightforward. Usually what we do in clinic is we don't do the tests. Tests are prone to all kinds of problems, even though they're covered by insurance. But we often would simply take the gluten away for about 3 months. And if the patient has a substantial improvement, we will reintroduce. And if they have a side effect when we introduce, you sort of say you're probably worth staying 6 to 12 months without it and then slowly reintroducing. So that's our usual approach. Let's go to next slide. So the detox defects are now in real practice. So when I was giving this lecture, say 6 or 7 years ago, these tests were just beginning to be common. Nowadays, you can assess your own genome quite easily, and you can identify, genetically speaking, why or why not you may be at the higher risk to accumulate certain toxins. Now, this requires a pretty sophisticated practice style, but nonetheless, I decided that it's important to mention this. So this is just one test that can highlight what are the problems that a given person have in phase 1 and phase 2 detoxification. And if you know what those problems are, you can actually bypass them. So I'll show you in case of MTHFR, it's really important that you can bypass that very easily. Let's go next. So, but why is it whole conversation important? Well, we know that MDS and AA actually can be caused by a number of toxins. There's a really good links to benzene, lead, arsenic, and possibly other metals, including mercury. Mercury, for example, is undoubtedly a cause of all kinds of problems that not just cancer related, but others like insomnia, hypertension, diabetes, and the whole list of concerns that mercury can lead to. Let's go to the next slide. So the common wellness strategies that we use in our clinic and at universities is, we try to, the point here is if you're not feeling well, it's really hard to have enough energy to cope with the treatments. We do believe that outcomes are worse, and actually there is a increasing amount of evidence to support what I just said. In fact, there are pretty large NIH-sponsored trials looking into things like acupuncture, massage, yoga for cancer. And of course, they're looking at it from wellness perspective just to make patients feel better. But they're also assessing outcomes, and we do feel that there are probably some positive outcomes, and they likely related not necessarily to directly treating the tumors, but to the fact that your immune system gets stronger, you feel overall better, and maybe it means you will be able to go through entire chemotherapy without ending it too early because you can no longer tolerate it. So all these methods listed are actually can be valuable. The biggest problem is quite often they're not covered by insurance, and so it creates a kind of a separation between those who can afford them and those who cannot. But some modalities like Tai Chi and yoga can be practiced very cheaply. You can learn basics and continue improving your practice. Notice I don't really like calling it exercise, even though there that says exercise, but they're really practices. And also some of the mind-body practices can be learned in a class, like for example, MBSR, mindfulness-based stress reduction class, which is an 8-week class that can be taught learned within 8 weeks and then practiced after. So let's go to the last couple of slides. So acupuncture has a really strong evidence for nausea, vomiting, and symptoms that are often come with cancer. It's generally safe. Increasing number of insurances covered it. Let's go next. Tai Chi, in contrast, doesn't have a lot of insurance coverage or evidence. By the way, this is my teacher, Master Lu, and it's a Wudang style Tai Chi and Kung Fu. But Tai Chi has a really interesting data saying that actually it appears, in contrast to regular exercise, it has better outcomes for all kinds of conditions, for insomnia, for decreased muscle, so slower muscle loss, so staying stronger longer. And you know, in Asian countries and China specifically, Tai Chi is often prescribed for patients with cancer as a therapeutic exercise. Now, we have less of Tai Chi compared to yoga in the US, but I think it's just a matter of time. As Tai Chi as a whole field grows and becomes more standardized, we're going to see programs, clinical programs utilizing Tai Chi more and more. Let's move on. And yoga, as I said, that actually, there is a trial even with lymphoma showing a benefit on overall quality of sleep and potentially even less use of sleep medications. One thing specifically, most of the larger cancer centers now do have yoga teachers, including our own center. So do look for that. During the COVID, I think a lot of the yoga and Tai Chi 2 practice have shifted to the online. So you can just simply join Zoom like you're listening to me, but instead of listening to me, you will be there on the mat practicing. So let's move to the next. Massage can be very beneficial. Unfortunately, not a lot of centers offer it. And this, of course, has to do with the insurance coverage. Also, not a lot of insurance can cover the massage, but it can be quite supportive for all kinds of symptoms. Let's go next. And there's a growing amount of evidence for mindfulness approaches. And this is one area where the cost is really often not a big issue, and you just really have to commit to it and practice and find a possible supportive provider who can gradually guide you and who you can talk to and sort of use that person as a reflection to figure out what works best for you. It doesn't even have to be a medical provider. It could be a good friend who understands this, a mindfulness teacher, etc. Let's go next. And then here's some online resources, and I think this is the last slide, or maybe there's one more. The books. So Full Catastrophe Living is a great book to understand the importance of mindfulness. Integrative Oncology with Donald Abrams, who's one of my mentors, is an excellent book. It's a little outdated right now. I'm not sure if the newer version will come. Personally, I love Cancer Fighting Kitchen. It's not just book of theory, it's practical. I mean, there's recipes and very specific recipes for specific situations. So I would look into that as well. And I think with that, we are done with the slides. And let's do questions. So I am seeing questions. So I'm just going to go from how they came. So the first one is Wim Hof method. I'm a huge fan. I've been doing Wim Hof method myself for about 10 years, and I've worked with almost all of my patients integrating cold exposure. There's a very profound impact, beneficial impact on the immune system. I don't think there's any specific cancer evidence, but I talked to Wim himself, and they are planning on trying to do some trials on cancer. The problem, universally, this is a pretty extreme intervention. Literally, you over time learn to get yourself exposed to cold temperatures with specialized breathing. And so they're a little hard to study in patients who have multiple complex comorbidities. I think their goal for now is to start with the simpler conditions and then gradually research this. So would curcumin have any meaningful activity against platelet synthesis? The answer to that is maybe. We usually stop turmeric before surgery for a couple of days. I have never seen turmeric cause bleeding. I think the bigger concern is interactions with some medications, but there are not too many, so that's the good news. Next question is, what supplements would you recommend taking during a bone marrow transplant and after? It's a very complicated question. Actually, during or before the bone marrow transplant, I tend to give patients more of not anti-cancer treatment, but more of a whole body support. I definitely think the K2 and vitamin D are important. I think fatty acids support is very important, and also very important connective tissue support. So things like vitamin C, zinc, collagen. So those are something I use quite often. I do often recommend something called bone broth, which is a natural source of collagens, which are food-based. And I mean, it sounds gross, don't you just make broth out of bones? But it often tastes really good. It's a very nurturing food, especially in the winter, and it tends to help the tissues to recover from whatever their insult, and including the bone marrow. So, and you know, there's an interesting potential of certain more aggressive interventions like intravenous vitamin C and mistletoe, but I wouldn't go there because I think doesn't really have a lot of supportive evidence. So integrative approach to manage ascites, unfortunately, I'll say there's really none. I had my staff do acupuncture in these cases. Sometimes it helps, but unfortunately, usually ascites is a sign of a pretty progressive condition, and anything that's more advanced tends to be harder to treat. Diuretics, natural or medication-wise for ascites, don't really work really well. So, and I think that is all I have for questions, unless anybody else have anything last minute.
Thank you, Dr. Kogan. We have two more questions. One is, what was the proportion of K2 to vitamin D?
There is no, you don't need to worry about proportion. What I tell people, if you're taking vitamin K2 for any cancer, whether it's mild dysplasia or any solid tumors, the dose is 15 to 45 milligrams, usually 30 to 45. For solid tumors, vitamin K2 is probably less important than for hematologic malignancies. So there I'm universally giving, but it's MK4, not MK7. MK7 dosing, I don't know, and I don't use it for cancer, so I'm not sure what it would be. But for the bone health, it's somewhere between 50 to 250 micrograms. It's a pretty broad range. So optimize vitamin D levels so that it's 40 to 60. And then take 30 to 45 milligrams of MK4.
Thank you.
See if there is another question.
Sure. Do you have any suggestions on how to boost red cell production for patients?
So melatonin is one. There's a good data for that. You know, people traditionally also historically used bone broth as a stimulant for all cell lines. I don't think there's a lot of evidence for that. But those are the two things that I can immediately come up with as to sort of very simple, very relatively low cost and easy with no side effects, things that you can do. Full fat, no. So there is no K2 sources in the food. They don't exist. So that's incorrect. It's vitamin K could be in certain types of dairy. There could also be supplemented. So if somehow cows were eating certain, I guess, foods, maybe there's going to be K2, but I'm not aware of K2 in any food source. I'm not sure that that can exist. Just because the way that K2 is made, it's made by bacteria, and I don't think it goes from the microbiome, from the gut into the systemic circulation to the milk. I think it's utilized rapidly. It's taken from the blood very quickly due to the nature of it. But, you know, maybe something I don't know. So I guess I'll look that up after the talk.
Thank you. And our last question, do you have any suggestions on how patients, what they could use to help with fatigue?
Right. So fatigue is a very universal problem, especially if the chemotherapy is used, but even without it. Cancer itself can often lead to fatigue. It's a lecture in itself. Usually what I say, I prefer start out with the simplest methods, and then the ones that are also cheap or very, you know, no cost at all, and the ones that can have a very profound impact. So for me, the first level of combating fatigue start with lifestyle. So sleep, optimizing if it's not optimized. Tai Chi or Qigong quite often is extremely profound. In fact, I find that combination of acupuncture and Qigong can cure about half of all the cases of fatigue, and rapidly. I mean, we're talking about a week or two. So it's not, you don't have to wait forever. It's a little more complicated if fatigue is linked to some nutritional deficiencies, to a very strong chemotherapy. There you could have a lot more trouble with, you know, correcting underlying causality of that fatigue. But that's where I would start. I do tend to often monitor patients' nutritional status. So there are insurance-based tests that are covered where you can check all the nutrients and say, oh, look, you know, you're low on B12. So low B12 is very commonly associated with fatigue. So, you know, repleting B12, and often not orally, because sometimes it doesn't work. You have to give injections, and also giving an active forms of nutrients versus inactive. So if you take, for example, cyanocobalamin, it's an inactive form. It often doesn't do anything because your body cannot convert it to methylcobalamin, which is an active form. And that's the form that I would use directly in all of my cancer patients.
Thank you so much, Dr. Kogan, for sharing your time and your expertise with all of us today. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820 extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice on information for bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family, as we have done for the past 37 years. This concludes our program. Thank you, Dr. Kogan.
Thank you so much. Bye-bye.